Thank you. It's so nice to be back in Egypt with my friends so that I can share some of the work that we're doing in Toronto looking at cochlear implantation in children. And the topic that I was asked to speak about today was overcoming barriers to obtain benefits. It's important. We talk about early implantation. We talk about implanting children and how much that is the future, and we've heard that already this morning. But in truth, the surgery is not really actually that difficult. It's actually getting the children to the surgery that is actually more of a problem in Canada. So before I begin, I want to acknowledge and tell you that I'm coming here and I'm speaking to you today, but truly the work that I'm presenting is the work of my whole program, and there's a tremendous number of individuals back home who do the work that I'm going to share with you today, both clinically and also the children and the students in the research team along with my colleagues. So this is really important that this is a team effort. So today in the next 20 minutes or so, I'm going to talk about a few concepts, and the first concept that's important is talking about the ability for humans to be plastic. When we put these two cochlear implants in, we affect the brain, the underlying brain, and it's very important that we understand that that human brain has the capacity to adapt to these cochlear implants and normalize the information that's coming in. My specific remarks today are going to be regarding implanting infants and how challenging that can be from a diagnostic, practical, and technical point of view. For the surgeons in the audience, you'll be disappointed. I only talk for a little while about the surgery because the real problem is getting the children to the operating room. So you've heard in some talks this morning already about the concepts of plasticity. This is a PET scan from Korea in 2000, this study, and it showed that the longer that the person was deaf, the less blue. And blue means nothing's going on. So if you leave a brain alone, it starts doing other things. We heard a talk earlier this morning about cross-modal plasticity, how the visual system will take over from an auditory system which is not receiving information. And then when we try and implant them, it doesn't work as well. So this is some work looking at cat brains. This is the tonotopic distribution of the cat brain. And if we raise the animal in an environment that's rich in certain frequencies, what happens is that area becomes more open to stimulation because the organism changes. That's plasticity. And we know in cochlear implants, the younger we implant children, this is implanted 36 months, if we implant them closer to under 1, they do better. In fact, they approximate the normal line for speech comprehension and expression. So clearly, earlier is better. It's clear that earlier is better. We capitalize on plasticity and we have the best return on investment for putting in the time and money to get these kids implanted. I'll shift gears. Hearing loss is common. These are the things that currently in Canada are screened for at birth, and 3 per thousand, the most common congenital deficit is sensory neural hearing loss. We heard that this morning from the Belgian study. But what I want to spend the morning talking to you about is that the determination of the cause and the diagnosis and getting the kids to the implant is really an important thing. This is a study from Diego Preciado when he worked as a trainee with John Grenwald in Cincinnati in 2004, and this has been updated several times. I don't want you to focus on that. I just wanted you to understand that getting a child from birth into the implant surgery is quite a task. The key in at least Canada is early screening. And these are groups of children who have mild, moderate, severe, and profound loss. This is the children who are referred to us with no high-risk factors. And you can see we don't get moderate and mild losses till age 7, the profound losses till age 2.5. Even with risk factor screening, we still don't do much better. Only when we screen every child at birth do we have a chance of catching these children early enough. And this is the implant by year of my program. And that's not what I want to show you. I want to show you that this is when we started universal screening, and this is the only year when we had more than 20% of our children under 1 year of age. This is Canada. I have all the money, all the access, all the tools, and I still, with a universal implant screening program, can't get them early. That's the point of my lecture. There's this group of children that I'm trying to get this early implant so I can capitalize on plasticity, and I can't do it. And I can't do it because of professional, diagnostic, parental, societal, financial, technical, ethical reasons, the same as the reasons that you're going to have trouble diagnosing and getting the children early. We all know earlier is better. What's holding us back? Well, I looked in my program at what is holding us back, and we looked at children implanted by age 3, 400 or so who were in our program, and they were delayed by late diagnosis, delayed referral, and slow assessment. And I want to share some of that data with you because it might be that even in Canada, what I found is something that's applicable here in Egypt. We looked at these children, and we looked at all sorts of things, from the time that the parents or the caregivers or they were screened noticed hearing impairment, all the way through the confirmation prescription of hearing aids seen in the program, all the way until the day of implantation, 18 different items. I'll make it simple, and I'll show you in pictures that the children who were implanted early, below age 1, you can see that every one of these little factors is a very narrow range. And the older they were implanted, when we looked back, there was a greater spread of assessment times. The mean and variation time for each process increases. So if we don't get them young, everything is slowed down. The easy ones are the easy ones when you get them early, and everybody, the family, the finance, the professionals, the audiologists are all on board. If there's any doubt or wavering, it makes it all very spread out. That was the first thing that we took home. And clearly, if you didn't confirm the hearing loss, it delayed your entry. The ones that had confirmed early hearing, they had a very short period of time. They were sent to see us. The longer it took to confirm the loss, the greater the variation in the assessment program. It doesn't seem to make sense, but that's the data. There's lots of reasons for delayed diagnosis. The family missed appointments, the process missed the hearing screening, there was an artifact, they had contradictory testing. A lot of children in Canada have recently immigrated, so there's no hearing screening in their home country, or there's delays in testing. But the most important thing is that there's progressive hearing loss after a passed screen. They pass the screen, then they go deaf. And the major reason why is cytomegalovirus, which I'm going to tell you about. It's the most important thing to happen in hearing loss in children in the last decade. It is more common than hearing loss, 5 per 1,000. 30% of the people in this room have antibodies for CMV. It's common. It's a herpes virus. It's a common cold virus. 10% of children who have it are symptomatic, and half of them have hearing loss. Forget about them. We know them. It's the 90% who are otherwise perfect. 10% have hearing loss, and those are the ones that often pass their screen. It's hard to test. You have to test them below the age of 3 weeks, the urine or saliva, or what we do in Canada often is archive their blood spot at birth, and also there's a way of looking on non-specific image findings. There's a white spot matter in the temporal lobe, 4 nerves, beautiful. There's some non-specific white matter changes that are indicative of CMV. So here's the point. This is the children with CMV and their hearing loss, but this is why it's such a problem, because it all happens here. They're screened right there, but they don't lose their hearing for up to a year. So CMV is the big mystery in neonatal screening, because we miss those kids. Clearly, once they enter the program, the later they enter the program, once again, we see a greater spread in trying to get the assessment done correctly. And this is the 3 groups: the early implant, over a year, and under 3. This is the early, and you can see that in each group, there's lots of reasons potentially why there's a spread in assessment. Now, in all groups, it's true that my team can assess them very quickly. So once they get to see us, we can get them through in less than 180 days, 6 months, which is probably ideal. But in all 3 groups, there's these children where the assessment just seems to go on and on and on, and we can't get them in so that we can implant them. Because remember, We started this show by talking about how early implant gets better outcome every time, and why can't we just diagnose them and get them in the operating room? Because it's not easy, or we would do it. I have a big program, and I can't do it more than 20% of the time. There's lots of reasons why there's a prolonged assessments, there's missed, there's canceled appointments, there's comorbidities of the child. These children are sick, they have additional problems, they have other issues going on. But here's the news, there's other comorbidities of the family. These families also often have many jobs, they have other children to look after, they have work, they can't come to the appointments, there's changes in the family. So children with deafness are not independently free of troubles at home. Their parents often have health problems, or the siblings have health problems, and this nested problem, comorbidities of the family, was one of the most important things that we looked at. How do we fix that? We have tremendous amount of social work help. It's not a surgical issue. So you thought you were going to come and see me and I was going to talk about early surgery, and I'm really telling you, you need more social workers. Because if you want to get them early, you got to treat the whole family. But it brings up something else, because the next biggest delay in getting them onto the table is imaging. And we've had a whole change in the way that we look at imaging in infants in Canada in the last little while, because we're aware now of radiation risks. So we hate CT scans. I saw Paul gave a beautiful talk about robotic implantation. I was writing it all down, and then I realized there's 2 CT scans during the course of implantation. We never CT scan babies anytime if we can, because we irradiate their growing brain. We save it for cases of malformations. This is phenomenal. I just wanted to share it with you. This is CMV being diagnosed on a fetal MRI. So the baby's not even born yet, and we've already got the diagnosis of MRI. I don't want to give you the impression that we do this all the time. I just thought that was an amazing picture, and I wanted to show it to you. What we generally do is an MRI only, and only add a CT scan concurrently if there's meningitis or temporal bone trauma, or subsequently, which means a second anesthetic, I admit, if there's an anomalous cochlea or a syndrome. Here's an absent nerve on the MRI. Here's some white matter changes. And my point is that when you get good at it, surgeons can figure out how to use the MRI and get almost all the information that they used to think they could only get on a CT scan. The sigmoid, the marrow, the fluid, the cochlea. Here they are on the MRI. You don't tend to miss any lesions once you get good at this. But sometimes you do need a CT scan. For example, incomplete partition type 1, oftentimes you want to see the structure of the nerve, but in this case we also identified this thing called a cochleocele, which is a CSF a pocket coming out of the foot plate because they have a deficient foot plate, and that's what causes the recurrent meningitis. So you have to pack that either at the time of surgery or subsequently. So CT scan is sometimes added. Sometimes it's added, for example, because you know it's going to be difficult surgery. There's a baby with the charge association, narrow nerve, and as Levant told you about many times this morning, you got to look for the aperture of the nerve. There's some venous sinuses that are present. It's a very abnormal hypoplastic cochlea. So when you want really fine additional information, you add the CT scan. And this is important because when this is, for example, just to show you, again, not routine, but in the charge, the CT scan is important because there's the facial nerve running there, but there's the other facial nerve, a second branch of it, running right over the promontory. There's the round window niche. So this is a type of case where you really want the additional information, although mostly cochlear implantation is an anatomic dissection. In this case, you really want to see because the nerve is running right over the promontory. There's the round window beautifully there, and simply just insert the device and don't hit the nerve. So imaging, cytomegalovirus, important. The third big thing that helps us get patients on the table quickly is a knowledge of the genetic underlying cause if present. So in our lifetime, since 1998, but earlier, but Francois Denoyel was the first in 1998 to publish about connexin 26, and now we screen for 84 genes when we screen. But the important thing about this initial introduction to genetics is it introduced the concept of intracellular channels. And it made, for the first time, the concept of pediatric hearing loss didn't have to do with hair cells. It had to do with maintaining ionic hemostasis in the cochlea. Because normally you have potassium in very low volume, low concentration in scala media. But through the connexin pathway, it's pushed from here and from here, from areas of low concentration, it's packed into this scala, so the resultant electrical charge is positive. So you have zero charge, positive charge. You have a battery. And as soon as the connexins don't work and don't pack the potassium in there, your battery goes dead. Everything's perfect. And this has allowed us to tell the parents, this is why the baby has the hearing loss, definitively. And when they used to say, well, maybe it'll come back, now we say, no, it won't, till somebody virally transfects it. So it's been really important. And now initially, when I got genetic results, I was bothered because 82% of them were variants of uncertain significance, and that doesn't help you with a family that is unable to move forward because they need something for sure. But interestingly, now I look at it the other way, because 14% of the time, it's the cause of the hearing loss. And I can tell the parents, this is the reason why your child's deaf, and this is the mechanism. And they're much more able to move forward with the decision towards implant. So in Ontario, which I'm proud to say is the only place in the world, we screen both for common genetic causes of connexin and pendrids, but also for CMV, just starting last August. So there's going to be a number of very important findings coming out of our work, because we screen a number of children and then manage them. So, because of all this hard work in identifying and overcoming the barriers, we're over 20% for the first time in a long time, and this year's number should hit 25 or 28%. So my point was, there are barriers, you can overcome them. And that's really what I wanted to tell you about this morning, because that's important. But for the surgeons, we implant young babies since Coletti did it. This was a 3-month-old who had meningitis, so he went very early. And there's really nothing to it. So I've only saved 2.5 minutes to talk about the surgery. You have to be conscious of the blood volume. You have to plan appropriately so that you can get into the cochlea knowing there's going to be marrow and you're going to have to slow down there. It's really important that your judgment is on high, because you have to reduce the bleeding in the marrow as it happens, and you have to be prepared to stop. You must leave your ego at the door. You have to manage the heart rate of the baby and your own heart rate. If you're uncomfortable, stop. There's no point in early implantation if it gets you more complication. That's what I always try and teach. It's just a simple operation. But like any operation, you have to be extra cautious of blood loss and planning in this one. Just for example, and everybody asks, how come I use CT scans? Because it's a really old study. Because we've been doing infants for over 15 years now. These are all children 1 year of age, and clearly there's huge differences in the degree of mastoid pneumonization. This one's going to be a lot easier than that one is. So the caveat, the information that I tell you before you do it. Infant implantation is dependent on the skill of the team. As long as it's a safe intervention, you have to remember it's not the most important thing. The most important thing is the parents. It's the parents. Then maybe the audiologist and the speech pathologist, but it's the parents. And at the bottom of the list is the surgery. So an implant surgeon can't make a mistake just because they want to do an early implant. So always remember, it's not the most important determinant of success, and let's not get caught. If it's going to take you 4 hours to do it, don't do it. If you're getting better at it and slowly move down your age, good. Be prepared to stop. Because as I'll talk about tomorrow, the key to early implant is restoration. This is 36, younger, 1-year-old, just like the Naparco curve. Restoration of developmental trajectory. That's what I'm going to talk about tomorrow, is how the brain is restored to normality with early implantation and why that's so important. So we talked about early identification and treatment. We talked about how we could capitalize on the plasticity of infants. We talked about implanting infants and how the challenges can be overcome, and most of them, all of them, are non-surgical. We can develop these skills, we can get benefit. Early implantation is key, The key is identifying the children and getting them on the table and getting them off the table safely. Restoring developmental trajectories. I'll talk about that tomorrow. Thank you.